Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
I know it's right on time, and to be respectful of your time and everybody else's time. I know we'll have more people joining us, but I do want to get started. I wanted to welcome everyone to another Tennessee Heart Health Learning Collaborative. Today we have a great speaker with us with experience from bedside to boardroom. Ms. Smith leads Target BP, an initiative the American Heart Association and the American Medical Association designed to help healthcare organizations to improve blood pressure control by providing education, resources, and annual awards for improvement. Since taking this role, the initiative has grown from 330 to nearly 1,900 participants, participating healthcare organizations serving over 9 million patients with hypertension. More than 1,000 organizations have achieved BP control rates of 70% or higher. Nearly 1,700 have adopted evidence-based BP measurement practices. Ms. Smith led the development of the clinical core curriculums as part of the National Hypertension Control Initiative, a HRSA OMH-funded demonstration project supporting 350 FQHCs to improve blood pressure control and implement self-measured blood pressure programs. From their 2020 pandemic baseline of 51.1%, the NHCI FQHCs improved the blood pressure control to 60.9% in 2023. Previously, Ms. Smith served as VP of Strategic Initiatives for C-Change, a national cancer not-for-profit, and worked for 15 years as a nurse, administrator, and consultant in hospitals across the country. In her professional volunteer role, she served for the last decade at Johns Hopkins University School of Nursing's Advisory Board. She also served as public member for an accreditation council for graduate medical education family medicine residence review committee. Ms. Smith earned her bachelor's in human biology at Stanford, a bachelor's of science degree in nursing at Johns Hopkins, and master's of public health degree in North Carolina, Chapel Hill. So with that, I will pass it on to Ms. Smith, and thank you so much for being here today.
Thank you so much for the invitation, Gladys. I really appreciate it and the opportunity to be with you all. I appreciate that we have a smaller group so far, and hopefully the numbers will grow, but I'm delighted to interact with any of you as we go along today, to raise your hand, interrupt me, put a comment in the chat, whatever is most convenient for you, but would love to make this valuable for you all. So I'm going to dive in here. I know this is being recorded. I know there's a PDF of the slides to share with you all, so you should have ample access to share this or revisit the content as I dive in here too. So let me start by framing the challenge that you may be quite familiar with. We know that our national hypertension control rates have plateaued and have begun to slightly decline. This is lagging data, but we have our work cut out for us. We know that hypertension affects nearly half of adults. One of the most common conditions that can be diagnosed with, a $50 device, treated with low and no cost medications. This is sort of a winnable challenge, and we know we have lots of tools and resources to do so. So I also know that that experience isn't necessarily equal across all populations. And so when we think about awareness and treatment and control, there is still even more variability across populations. And depending on the population you serve, there may be some unique considerations for your practice. So with those sort of high-level challenges in mind, I want to dive into the solutions and provide some examples of things that we know have worked. We have evidence to prove they've worked. We have a growing number of organizations from across the country, big and small, who've been successful in doing so. So my hope is that that challenge that may seem daunting of, half of organizations able to patients having blood pressure control, we can do better, and we have a lot of growing evidence to do so. So one of my favorite publications, it came out last year. The AHA and the AMA released a scientific statement summarizing evidence-based strategies, implementation strategies, real-world strategies to improve blood pressure control. And it ranges from very big undertakings, addressing things as challenging as racism and bias, to programmatic undertakings like those that help support lifestyle change or self-measured blood pressure monitoring, SMBP, adopting more team-based care models, just some very specific implementation tools like treatment protocols, medication adherence strategies, much more granular strategies. This is I think, a great read. It's really practical. It's not a 200-page guideline. It's a more digestible literature journal publication. So I highly recommend it if you haven't checked it out, and think about what you're doing from these examples and what you might consider adopting. I want to talk for the majority of our time through the lens of Target BP and how our initiative has translated the science into practical tools, incentives, and resources to help your organizations improve. The American Heart Association and the American Medical Association, as Gladys said, launched Target BP in response to this high prevalence of uncontrolled blood pressure. And together we want to bring the latest scientific evidence to the fore, translate it into tools and resources, as I mentioned. We leverage the AHA guidelines and scientific statements. We also leverage the AMA MAP framework, and I'll talk about that in just a minute. We like to help organizations in their journeys to improve high blood pressure control, whether it's through self-guided use of our resources, participation in our educational programs, or taking advantage of some of the services and the experts that both the AHA and the AMA offer to organizations to improve blood pressure control. And I'll talk about that a little bit more in the end. And then annually, we recognize organizations for their commitment to improving blood pressure control, their adoption of evidence-based practices, and their actual attainment of high control rates. And there'll be more details on that as well. I mentioned the AMA MAP framework, and it is an organizational framework that we use to approach quality improvement in hypertension. And the MAP stands for Measure Accurately, Act Rapidly, and Partner with Patients. Measure Accurately is the first part of the framework, where we're really honing in on the common barrier of diagnostic uncertainty when it comes to a clinician wanting to assess some measurements and say, are they accurate? Are they representative of my patient's true blood pressure? And does that inspire me or give me confidence to make a decision or take an action? And so that's why we obsess about blood pressure measurement accuracy. And I'm going to dig into each of these as well. We Act Rapidly is the next phase of the framework, and that's really focused on addressing therapeutic inertia. Have we put in place the prompts, the resources to support clinicians in making rapid decisions, to make rapid diagnostic and treatment decisions to lower risk quickly and help patients improve control. And then Partner with Patients is not intended to be last in terms of priority. It's just that our team needs to measure accurately, our clinicians need to act rapidly in order for us to be good partners with our patients and help them with self-management strategies, including medication adherence, lifestyle change, and/or self-measured blood pressure monitoring. So that's the framework that we use to organize all of our educational tools and resources, and we'll sort of step through each of these as we go today. And I trust that Gladys will interrupt me if we have any questions along the way. One of the overarching resources I like to start with is this quick start guide. It's a combined quick start guide. It's kind of like a Matryoshka dolls or nesting dolls of quality improvement resources. And there's a section for MAP, measure accurately, act rapidly, partner with patients, and a separate one for SMBP because there's a lot involved there. And within each of those, there is a pre-assessment to look at your current practices in your organization, in your clinic, whatever your domain. There are educational tools. So there are free on-demand webinars with CME and CE credit that address each of these content areas. There are QI and practice tools, patient education tools where appropriate. And in many cases, we have 15 or more languages available in some of those patient education materials. So depending on the diversity of the patient population you serve, there are lots of resources there. So this one resource, sort of, again, there's links within links within links that can walk you through it all at once or bite by bite if you prefer to approach it in that way. So digging into measure accurately, I like to use the analogy of a journey. If you're going to have a safe journey, you need a safe car, a safe driver, and a safe road. If any one of those things is not true, you're unlikely or less likely to have a safe journey. So if you have a clunker, a distracted driver, or a road full of potholes, you're not going to get there safely. And so how that analogy translates to measurement accuracy is that the device that you're using to measure blood pressure is the car, the person taking the blood pressure is the driver, and the clinic processes that you've outlined to measure blood pressure are the road. So let's walk through that. In terms of selecting your equipment, your car, you want to buy validated blood pressure devices. Those can be found on the U.S. blood pressure validated device listing. And this means that they've been independently tested for accuracy with different patients under different conditions to have accurate blood pressure measurements. Then once you have that device or once you buy that car, you need to maintain it. And that's where calibration comes in. If you use manual devices, particularly if you use Android handheld devices, they should be maintained, they should be calibrated every 2 to 4 weeks. Very few organizations do this, and this is one of the huge downsides of using manual handheld devices. If you have wall-mounted or pole-mounted device, Android devices with the dial and the manual inflation, those should be calibrated every 3 to 6 months. That's still a tall order, and increasingly we're recommending using oscillometric devices, the digital ones. They have they usually are to be calibrated every 1 to 2 years or per manufacturer's recommendation. They also have an advantage of not having to attend to all of the psychomotor skills that the operator needs to employ to get an accurate measurement. And then they can attend to the patient's positioning and other things that will lead to a more accurate blood pressure measurement. So with that, I will talk a little bit about what some of these positioning errors and how important it is for the person taking the blood pressure to attend to these things. And so making sure a patient is seated in a supportive chair with their feet flat on the ground, their arm resting at heart level, a cuff over their bare arm, not over clothing, that is properly fitted, and that they've had an opportunity to empty their bladder prior to measurement. We also want to make sure that as I mentioned, that the cuff is properly fitting and they've had an opportunity to rest for 3 to 5 minutes before taking a blood pressure. Obviously, each one of these errors can translate into major measurement error if not attended to. So if a patient, if you're off 10 millimeters of mercury from an accurate measurement, that could be the difference between a different level of diagnosis. It could be the difference between wanting to intensify treatment or not. So really making sure that every patient, every time in your care, has their blood pressure measured the same way is really critically important to support your clinical team. The steps.
Quick question.
Sorry. Yeah, please.
I'm sorry. If we can go back,
yeah.
I had somebody put in the chat. How do you know if the equipment has been calibrated? Is there a notification label, or you just have to know?
That's really up to your institution, and it's a great setup for a resource that I'll share with you that can help your organization figure out how to do that. Large organizations often have a biomedical department that is responsible for that, but sometimes they only check to see if there's cracks in the tubing or the cuff bladder. Really what they need to do is use pressurometry, which is usually a mercury column where they're comparing it to a gold standard and inflating the cuff to see if there's consistent measurement. You can also have third-party organizations provide that calibration services in some markets, and manufacturers also of the device itself can provide that service typically. That said, there are 500 or more blood pressure devices on the market, so I can't speak to specific ones, but what your organization's policy is and how you track it and how you carry out that procedure is going to be unique to your organization. But we have a policy and procedure template that may be very helpful, and thinking through how that works in your organization, which you may be the person charged with leading, or you may need to find the person who is leading that, but hopefully that tool will at least help start that conversation. Thank you for that question. All right, moving on to, so we talked about the safety of the equipment, we talked about the dependability of the person taking it and their training, and then the actual process of moving a patient through that care process. So before they even arrive at your clinic, you might remind them not to have caffeine, tobacco, or exercise 30 minutes before arrival. You might give them the opportunity to empty their bladder, to rest for 5 minutes, making sure that in every exam room there is a chair, there is a place to rest your arm at heart level. There are visual reminders, perhaps for your care team, those infographics that were on the prior slide that you can print out and hang up. You can wallpaper your clinic with them if you wish. And then during the actual acquisition of the measurement, you're wanting to do an initial reading, and if that's typically organizations, if that first reading is elevated, they'll repeat after a 1 to 2 minute rest. The diagnostic recommendation is to measure blood pressure 2 or more times on 2 or more occasions before making a diagnosis, and averaging those readings. And then it's obviously important afterwards to document those readings, and also to notify the clinician of those elevated readers. That might be an EHR message, that might be a signal. Some people put like a red heart magnet on the door frame, or put a card on the computer keyboard in the exam room, something that draws the clinician's attention to that abnormal reading. And those are things that have really helped not let that one particular issue get lost in a long problem list of issues for patients. And so this, I mentioned, we created a blood pressure measurement policy and procedure template, and it has the things you would expect to find in that, which is sort of step 1, step 2 of actually measuring blood pressure. But it also includes the important aspect of procuring and maintaining your devices, and training and testing your team. The guideline actually recommends training your testing in your team every 6 to 12 months in blood pressure measurement. Not because it's hard, it's often the first thing that we do in nursing school or medical school or medical assistant training. But there are a lot of little things that can go wrong if they're not paid attention to, and translate into 5, 10 millimeters of mercury error, which over or under treating hypertension is dangerous and has consequences. And so hopefully this template, it has lots of ways you can sort of customize it for your own setting, but it's a great way to evaluate what you have, or start from scratch and use it if you don't have a blood pressure measurement policy and procedure. So that's a quick overview of the measurement, all things that I wanted to share today about blood pressure measurement. I'm going to dive into the next phase, but again, stop me along the way. So acting rapidly, again, we're focused on the major barrier of therapeutic inertia, the things that interfere with the clinician's supporting environment to make decisions rapidly, to diagnose or treat hypertension. There is a webinar on this topic, as there are on each of these areas of the MAP framework, and I really encourage you to watch it. It's a great webinar provided by my colleagues, my physician and pharmacist colleagues. And these are the high-level points in that webinar, and they really emphasize the opportunity to use single pill combination medications, meaning 2 drugs from separate classes that are combined into 1 pill, and they talk through the evidence base for that. And I'll talk a little bit more about that, but they emphasize the use of treatment protocols, and we'll touch more on that. And we also talk about the importance of frequent follow-up. We know that intensification enhances survival. We know now that adding, when a patient's blood pressure is not controlled and they're on one medication, it's more effective to add a second medication from a different class at a low to standard dose. You'll get better blood pressure control and fewer side effects, as compared to just taking that one existing medication and ratcheting the dose up. Because the farther up maximal dosing you get in medications, you get less significant steps in blood pressure control improvement while you accumulate more side effects. And so it's better to use 2 medications at lower doses to get better control with fewer side effects. Ideally, those 2 medications can be combined into one pill, and there are an increasing number of those combination pills available. That's going to be dependent upon your pharmacy, the patient, your state's cover, like Medicaid coverage, and what pills they might have on their formulary. But again, there are an increasing number. We really emphasize treatment protocols. It sort of gets us all on the same page, all clinicians, all care team members, and so we can work together better as a team if we have a common game plan. And then we also, well, with that, I'll dig in here. Just some of the reasons why protocols are so effective in improving, some of the most outstanding performance that's documented across the country. Organizations have thought long and hard about their treatment protocols. They use them. It's not just on paper, it's actually in practice. And they emphasize a simple dosing regimen. So if a patient's blood pressure can be controlled with a daily dose with a low or no cost medication, that is ideally combined into one pill if needed, and that specifies timely follow-up. So the guideline recommends that patients are seen again in 1 month if their blood pressure is not at goal, to reevaluate, to intensify, to address adherence or other issues that can help improve blood pressure control. So there are a lot of reasons. Yeah, Gladys.
Another question just came in. Does seasonal temperature affect readings such as 95, degrees summer in Memphis? That's a great question. Yeah.
That is a great question. And I do not have an answer off the top of my head. Certainly, when heat is higher, people tend to be perspiring more and could have the potential of being dehydrated. That said, hot temperatures can also, I believe, elevate blood pressure. There's a whole literature about this that I think there was something published just in the last 6 to 9 months on this very topic. I will look up that article after our call today, and I will forward the link to Gladys to share with you. It's a great question that I can't answer off the top of my head, but thank you. So on the topic of medications, I have a quick question to think about, and we don't have a poll set up here, but thinking about what is the most powerful driver of blood pressure control. And I'll walk you through another study that I found really compelling. And the options here, these are all important. Medication adherence is important. Timely follow-up is important, and so is treatment intensification. And so just thinking in your own mind what you think might be the most powerful driver of blood pressure control. And when I asked this question in a poll, I think 9 times out of 10, or maybe 9.5 times out of 10, people say, oh, medication adherence is the biggest driver of blood pressure control. And that's certainly a reasonable thing to conclude. Let me walk you through this simulation study, and you may come to a different conclusion after we do that. So this simulation study took real-world data and looked at those 3 variables of patient adherence, encounter frequency, and intensification rate by clinicians. And on average, what they found in the published literature was, on average, medication adherence was about 57% for that encounter frequency for patients with blood pressure control. Uncontrolled blood pressure was about every 13 and a half weeks. And the range of intensification rate for clinicians was 13 to 33%. So that's the baseline that they were using in this simulation study. So then they started walking through different scenarios. What would happen if we ratcheted patient medication adherence up to 100% and we left everything else the same? Meaning they would still come back every 13 and a half weeks. Clinicians would still intensify medications at their base at the 33% rate. How high would blood pressure control rates get to if we got up to 50? They would get to 57%. So you would get a jump, and this was starting out at the national average, which is around I think the baseline they used was around 50%. So you'd get a bump in blood pressure control if patients were perfectly adherent to blood pressure medications. Now let's think about just changing the encounter frequency. Let's just say we brought patients back every week, which is pretty rapid, like probably unrealistically rapid for patients and clinics alike, but let's just, for the purpose of argument, what would happen to your control rates if you brought patients in every week, assuming that they had 57% adherence and assuming that they had 33% intensification rates from their clinicians? Control rates would bump up to 67. So visit frequency certainly is also a driver, more powerful than medication adherence, actually, in driving blood pressure control rates. And then what would happen if we got intensification rates up to 62%? And that would mean, it's never going to be 100%, but what if we could get intensification rates up to 62%? Your blood pressure control rate would skyrocket to 80%. That's even when you were still only seeing patients every 13 and a half weeks, and patients were only adhering to medications 57% of the time. So the point is that treatment intensification is the most powerful driver. A patient cannot take a medication she isn't prescribed. That's the real driver of blood pressure control. There's other things that are important: visit interval, medication adherence strategies. We want to pay attention to all of those things. But if you really want to move the needle in your blood pressure control rates, it really is an important role for your clinicians to play in treatment intensification.
I have another question over here. Have you seen anything comparable to this study that has studied the lifestyle changes in controlling blood pressure?
So I appreciate that question, and I have a little bit just actually coming up in just a slide or two about the impact that lifestyle can have on lowering blood pressure. But adherence rates in lifestyle change are certainly can be challenging also, and we certainly have a growing body of literature to know the things that are likely to help people be successful. And I'll talk about that just in 1 second, if you don't mind. And I really appreciate that question. That's a great one. Thank you. I just want to put on a quick plug for team-based care also. That is a guideline recommended approach to providing hypertension control. And when there's another very interesting study, if the average primary care clinician provided guideline-directed care for all the guidelines that he or she is accountable to, it would take on average, with an average panel size of patients, it would take on average 26 hours more than a day of time per day, which is obviously ridiculous. But when you translate that into a team-based approach, and everyone is practicing at the top of their license, that could be as manageable as nine. That's still a long day, 9.3 hours per day, but it just helps to make the case why, if we're going to practice guideline-directed care, we need to function as a team. So just a plug for that. These are two other two other publications that I really wanted to bring to your attention that I think are great reads. One is a medication adherence strategies that the AHA published last year that's specific to hypertension. It's a relatively short article and has some high tech, some low tech, and other strategies for improving blood medication adherence in hypertension. So I really think that's a great article to reflect on and think about what your organization is doing systematically and how it might incorporate more of those practices into your care strategy. And then the other is published by the CDC and Million Hearts, which was looking at what states cover fixed dose combination pills, the combination pills I was referring to before, in their Medicaid plans. So that's certainly worth taking a look at as well. These are just some examples of algorithms that you can use to inspire one in your organization, or use as they are printed here. And there's some examples. The one thing I do want to draw your attention to is there is a new hypertension guideline coming out next month. In August. It is likely to come out in the first or second week of August by the American College of Cardiology and the American Heart Association and many other endorsing organizations. And we are hosting a Target BP webinar with 4 of the writing committee members of the guideline, who will highlight the changes. They will reinforce the things that haven't changed that we still might not have had broad adoption on. They will discuss all the important points listed here: diagnostic thresholds, some of the cardiovascular and cognitive risks of uncontrolled blood pressure, how to calculate risk and take that into your diagnostic and treatment decisions, and think about appropriate use of medications and combination pills to improve control and adherence. And so I hope you can join us. This is free. There's CME. It's going to be an hour and a half. We really encourage you to join us for this coming up. So now let me shift gears into partner with patients to get back to the question that you asked earlier. And that is, partnering with patients, obviously we're thinking about collaborative communication strategies, lifestyle change, self-measured blood pressure monitoring, all the things that will strengthen a patient's knowledge of their own health, the things that are modifiable lifestyle risk factors, as was brought up in the question, as well as other things that they can do to monitor their blood pressure and improve control. So we have, as I pointed out earlier at the beginning, there's a set of tools just dedicated to this topic where you can assess your practice, watch an enduring CME webinar to learn more about strategies to improve control, and also think about, dive deep into self-measured blood pressure monitoring if you wish. This is an example illustrated here at the right of a patient education tool that we really love, and it lists the evidence-based interventions that we know can improve blood pressure control, what the recommendation is, and what is the potential or average blood pressure, systolic blood pressure reduction that can be achieved with that intervention. So for example, if you adopt a DASH eating plan, that could result in 11 millimeter mercury blood pressure reduction. If you increase physical activity, it could be a 5 to 8 millimeter of mercury reduction in blood pressure, as an example. And I think this is a way to have a conversation with patients about using collaborative communication techniques, about what their goals are, what they would be willing to consider changing, bite-sized changes, not changing the whole world. There's a whole literature around strategies that help improve adherence and success with this. This is hard work, but we know things like writing down goals, sharing goals with accountability partners, engaging in group activities, whether it's learning about cooking or exercising together, or having other members of your household adhering to similar approaches. All those support systems help. We know that reminders help. There are all sorts of adherence strategies and structure that helps people be successful, whether it's by changing their diet or their activity or other lifestyle risk factors. So it's a great question. And I think it's a very individual answer. We know, like I said, there's a body of literature of the things that can help drive adherence, but they, need to be implemented and considered on a one-on-one basis. Any other questions coming up right now, Gladys? Are we good for?
I think you're good.
All right.
Yeah.
Thank you. Here's another example of what we call a policy and procedure template around lifestyle modification. We just released this year, and you can download it, and basically walks through what is your organization's systematic approach to lifestyle change? What risk factors are we assessing? Who's responsible for assessing them, whether it's collecting biometric data, whether it's interpreting that data or whether it's intervening or referring patients to take action on those risk factors. And the policy is designed to apply to most adults. It does not include a specific assessment of social drivers of health. That is certainly something that needs to be taken into consideration with any lifestyle assessment of what other barriers might stand in the way of patient pursuing or achieving those. So that should be done together. But it's really an important part of an overall hypertension control strategy. The policy prompts you as an organization to inventory what resources you have to address these documented risk factors. So do you have cooking classes? Do you have educational materials? Do you have community resources you can refer individuals to? Do you have in-house counselors or others? Do you have other food pantries or food prescriptions or physical activity prescription strategies? There are a lot of different ways that organizations can take on sort of within their institutions or with community partners to access resources for patients who could benefit from that support. And then, as you know, this little flow chart in the lower right here sort of mirrors the policy steps that are outlined in this document that allow you to think through how is that going to play out in my organization? Who is going to be responsible for each? Because one of the things we know from the literature is that care teams, nurses, physicians, and others often don't feel well prepared from their education and training to address this. So they are oftentimes welcoming knowledge, training and support, which we offer in these resources. We also find that role clarity isn't great. And so who's asking what? Whose responsibility is it to ask the questions, to document the responses, to make the referrals, to follow up on and close the loop and reassess, on a subsequent visit. So I think it really helps you think through how to systematically approach this really important component of preventing or improving control. And one of the things I heard recently by an expert was a nephrologist who specializes in hypertension control. She said, sometimes we think with patients with resistant hypertension or very complex advanced disease that that lifestyle isn't important. It is as important, if not more so, for those patients because they need every strategy available to control their blood pressure, reduce their risk, minimize their organ damage, and other complications that are occurring with their hypertension. So I'm going to shift gears into self-measured blood pressure control so we can wrap up and leave more time for questions at the end. Self-measured blood pressure monitoring has I'm sorry, Gladys, did you have another question? I caught you out of the corner of my eye and I
No,
sorry.
no,
Okay,
we're good.
Go.
Nobody,
all right,
no other
thank
questions.
You. I meant to check in before shifting gears here. So self-measured blood pressure monitoring is a guideline recommended approach or adjunct to hypertension control. And the evidence is strongest when it's used to confirm a diagnosis of hypertension. So getting out of office measurements when in-office measurements may be elevated, it can help rule out white coat or masked hypertension. It can also be useful to clinicians to get out of office readings when adjusting medications and figuring out a patient's response to treatment if more or less medication is needed to get to control. It can also be useful in longer-term support to promote medication adherence and help a patient see over time some of the blood pressure control improvement they might achieve through lifestyle change. That just takes longer than taking a medication. Both are really important. And so as you go down this list here of 1, 2, 3, the evidence-based is strongest at the top, but it's growing across those other categories. I think some of the important points that I've listed here to the right these are frequently asked questions or kind of oversights. Handing a patient a device is not going to improve their blood pressure control. It's not the device that drives the control. It's sort of how we use the information that it generates. And so speaking of generating information, it's most helpful to clinicians to have a systematic sample of data to look at. One random reading here, one random reading there is not going to increase a clinician's confidence in confirming a diagnosis or intensifying treatment. What's recommended is that a patient measures his or her blood pressure twice in the morning before they take medications, about 1 to 2 minutes apart, and twice in the evening before bed, about 1 to 2 minutes apart. And doing that for 3 to 7 consecutive days, averaging all the systolic numbers, averaging all the diastolic numbers, to get an average daily mean for the clinician to consider about what blood pressure control looks like in that course of time. Some patients can't do this every day for 365 days a year. That's totally understandable. And so to have a discrete sample to help inform the next decision is great. SMBP is not something that all patients can take on, but this is the sort of the guideline recommendation for its use. There are a ton of tools that I want to share with you really briefly here. If you are considering or have a self-measured blood pressure monitoring program, this is a free online course that has a bunch of different modules. You can log in and out and pick up where you left off because you create a free account. The AMA created it last year as part of the National Hypertension Control Initiative. And it has it's everything from the basics of measurement and preparing patients, but it also helps you think as clinicians how to use that information. It also takes on bigger topics like how do we get leadership support? How do we engage our clinicians? How do we pilot it and then roll it out to more clinicians or more clinics? How do we engage patients? How do we evaluate if it's working? So this is a really detailed, each one of these modules is only like 10 minutes, so you can kind of take it a little bit at a time. But I think it's a really thoughtful way to think about a program, whether you're contemplating one or you have one that maybe isn't working as you had hoped. This might give you some insights into how to strengthen it. These are also all available on the Target BP website. These are a terrific set of tools to help, like a training. I love the one on the left. It's a checklist for your care team to help set patients up for success, from getting them a properly fitting cuff with their device to teaching them how to measure their blood pressure using a return demonstration technique, establishing a plan where how are we going to capture the readings? How are we going to get those readings back to our care team? At what frequency? Is it going to be on a piece of paper? Is it going to be over the telephone, through the AHR, or maybe a more sophisticated electronic transmission? But really helping you think through those steps. There are these great 3-minute demo videos in English and Spanish. Patient can watch those again at home if they wish. And then this visual reminder for patients of how to prepare, position, and measure their blood pressure. And there are also recording logs, how-tos. These are all the language translations that are available. Or if you want to take on a loaner, have a loaner program, there's some tools that can help you track devices and create a little loaner agreement for patients. So I'll whip through those. But my advice for SMBP programs, having worked with 350 federally qualified health centers trying to do this during the pandemic, is spend a lot of time on planning. Really think about what devices are compatible with your EHR before purchasing them, and thinking about who's going to do what, how's the information going to flow, are we able to code and bill, and then thinking about piloting it with just a few clinicians and a few patients, and really testing all the steps in the management of the devices, the data, and the decisions, evaluating what's working carefully, fine-tuning it, and then scaling it accordingly are things to, it's not for the faint of heart, but it can be extraordinarily powerful. So I'm going to shift to the last section about outcomes and just thinking about what are the, what's the end game here. When we think about outcomes, blood pressure control rates are really a lagging measure of success. We also want to encourage organizations to think about process measures, that the leading measures that get you to that lagging control rate. If you happen to be an Azara user, Azara Drives has a suite of AMA MAP hypertension metrics, and these are process metrics that look at the rate at which you measure blood pressure with a confirmatory measurement. So if that first blood pressure is high, did our care team repeat the measurement or not? It's probably never going to be 100%, but it certainly shouldn't be 60%. That's a quality improvement activity that would be really meaningful for your care team to take on. Similarly, if you look at intensification rates, which we were talking about earlier, it's not going to be 100%, but it probably shouldn't be 20%. And that's when you use this tool in Azara Drives, you can cut and slice the data by clinician and location and patient population. You can look at the data in different ways to see where there's opportunity to improve. It also looks at this is a proxy for medication adherence, but if you intensify treatment on one visit, when the patient comes back, is their blood pressure lower or not? And again, it's a proxy for adherence and a prompt for a conversation, but you want to look at strategies, looking at that data might help you improve your blood pressure control. So there's more information in the appendix about this. So if you have Azara, but these concepts of blood pressure, confirmatory blood pressure measurements by your care team, intensification rates by your clinicians, and adherence rates of patients taking medications. There are other ways to look at that. If you don't have this information system, as an example, you can do old-fashioned chart review. You can use other population health tools to look at this. But these are, ways to look at leading process measures to drive your lagging control rate measure. I also want to just touch briefly on annually, Target BP celebrates organizations for their commitments to improve blood pressure control with awards that reflect different adoption of evidence-based practices and high control rates. This is 2024 data. We have the 2025 preliminary data in our hands now. It's looking like we have more than 2,300 organizations participating this past year. It looks like we've had about 12 million patients with hypertension reached through the participating organizations. I don't have the attestation numbers yet, but they're going to be higher than the ones that are here. And we have well over 1,000 organizations who have achieved control rates of greater than 70%. That defies the national average. And that's really exciting to see organizations who have the leadership commitment, the clinical champions, the team focus, to invest in their education and their practices, that you can improve control. And these are organizations from across the country, big and small, academic medical centers, federally qualified health centers, rural, urban, you name it. It's possible anywhere. And that, I think, is really hopeful. For those of you who may not be familiar, in addition to reporting your blood pressure control rates, we also ask you this set of 30 questions about your blood pressure practices. And it's just yes, no, or unsure. I don't need details. I don't need evidence. I just need yes, no, or unsure. And it's about your blood pressure measurement. So are you using a protocol? Are you confirming measurements? Are you training and testing your team? Are you using calibrated, validated devices? For acting rapidly, are you using a treatment algorithm? Are you having follow-up within a month's time in that algorithm? Does the algorithm specify that? Are you using medication adherence strategies? Partnering with patients, do you have a systematic approach to assessing lifestyle risk factors? And do you have an intervention? Do you have interventions for them as well? For self-measured blood pressure monitoring, are you preparing patients for success? Are you training them, or do you have a measurement schedule? Or are you using that information to drive treatment? And then the last pillar is equitable health outcomes, where we're encouraging organizations to look at their blood pressure control rates and then stratify those control rates by race, ethnicity, zip code, whatever social driver of health might be meaningful to the patient population that you serve, to look for opportunities for improvement. Like, is there a population that needs more help to get to control? And so together, these criteria factor into the awards for which you are eligible. One more just comment on this before breaking for some questions in our remaining time is that this graph looks at organizations who have submitted their data annually continuously from the time they started. So the red line is organizations who started participating in our award program in 2017 and have submitted data every year since. In year one, we had 330 organizations. Now there are 50 who are still submitting their data, 7-8 years later. But what you can see by this visual illustration, this graph, is that people are continuing to improve. And organizations who joined in later and who are still continuing to improve are experiencing that same thing, with the COVID dip aside that we all experienced. But what I think is hopeful here is that if you can establish organizational commitment to improving blood pressure control and you stick with it, not only will you improve, but you will continue to improve, like year over year over year. I think that's what's hopeful and what is possible, as is illustrated here. So with that, I just want to wrap up by saying, you can visit Target BP for all the self-guided resources that I mentioned, the practice tools, the educational programs, the free CME. You can also consider participating in one of AHA's hypertension control accelerators. These are peer learning collaboratives that are 6 weeks in duration, 6 one-hour sessions with a lot of there's a little bit of didactic, a lot of peer learning, and barrier solution discussions that have proven effective in helping organizations improve their blood pressure control rate and adopt more evidence-based practices. The AMA also offers the AMA MAP hypertension support, and this is where a team of expert clinicians, nurses, physicians, pharmacists will work directly with your healthcare organization on data, metrics, training, care processes. None of the services on this page have fees associated with them. The expense is really your time and the time that you invest in improving your control. And then the local American Heart Association staff are terrific at helping sort of navigate organizations to these resources, and they're working across the country. So with that, I hope that you'll visit targetbp.org and find all the things I mentioned. Subscribe to our free newsletter. It comes out monthly, so you'll get the latest tools that are new. You'll get invitations to webinars that are free, including the one about the new guideline that's coming up. And you'll be able to easily access the on-demand or live CME events. We certainly encourage you to register to submit your data annually and achieve awards. I mean, there aren't a lot of awards out there for outpatient care, and we know how nice it is to celebrate your team's success. And there are there's a pretty extensive set of resources and links to the things that I mentioned in the appendix and the slides that you'll get. So let me pause there, Gladys, and see if there are other things other questions that have come up or things that you'd like me to touch on.
No, this has been fabulous. I know that we have some partners using Azara and they're not here. So I'm going to have to forward this information to them. I hated that they missed it because I know we've been working with them. And also just to let you know, I'm excited to see what you were sharing, because some of the flyers and things for the patients, we are sharing in our health hubs right now. So we were just printing some out yesterday. So I'm excited to see that. So I'm going to open up the floor to any questions, and whoever has a question, you're welcome to just get off mute and ask your question. No questions. Okay. Well, Asa, I would love to have you back. I know we talked about that a little bit, so maybe once we get through the summer, we'll have you scheduled for some regular intervals to come
my
and
pleasure.
share.
Yeah, my pleasure. Thank you for the invitation. And thank you for all that everybody on this call does every day to improve blood pressure control. It's definitely, when you think about all the health conditions that patients may be faced with, one of the reasons that I'm biased in saying start with hypertension is because you have the potential to save the most number of lives, because it affects the most number of people. And I think the benefits that organizations derive from focusing on one condition helps you think more systematically then about other conditions. So if you can have success in hypertension control and systematic approaches to how you train your team and organize your care and use treatment protocols and use data to identify gaps, then that same quality improvement experience, can transcend to how you manage cholesterol, how you manage diabetes or other conditions. But because hypertension affects so many patients, you're going to have the greatest benefit. You literally will save 3 times the number of lives starting with hypertension than if you started with another condition. So they're all important, and unfortunately for some patients, they all occur in the same body, and with many comorbid conditions. But we certainly it's certainly worth starting point. Anyway.
I have a couple of comments, great information. Thank you for sharing. I know Julie mentioned that she heard you speak at the Hearts of Hope.
Oh, so this is a repeat. Sorry for the repeat, Julie.
No, but this
well,
has been
hopefully
great.
The webinar for the new guideline was new information. I think that was one sliver of new information. We're really excited about it coming out. And I will tell you, I'm working with the writing committee members to plan that event in August, and they are so excited to really focus on the things that are most salient to primary care. And we've already it's going to be a case study heavy presentation. They're going to summarize, like, these are the big changes, here's the stuff that's so important, and then let's dive into case studies that apply these concepts to real world scenarios. And so, from the patient who's newly presenting without a diagnosis to a patient who has resistant hypertension, and sort of every scenario in between, highlighting those changes. So we're really looking forward to it. I hope you all can join us, or at least watch the recording afterwards.
I will definitely go register in a few minutes. So I'm excited to hear that. So anyway, well, thank you again. And I'll be in touch with you, and how we can come back and present some more topics.
Great. Thank you so much.
Thank you, everybody. Bye-bye.
Bye.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee, and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.